So I talked about the increased rates of obesity, insulin resistance, diabetes, hyperlipidemia, and metabolic syndrome. So what follows all those metabolic aberrations would be that ADT has a similar effect on cardiovascular disease. And Dr. Slovin has shown us a lot of data. And not only through the metabolic aberration pathway would you expect more cardiovascular disease, you would also expect it through the biologic mechanisms and the direct effects on plaque stability that I talked about a little while ago. So the problem is that large randomized control trials are lacking, and the existing evidence regarding CVD morbidity and mortality for patients receiving androgen deprivation is rather controversial. Data from observational studies does indicate overall a positive relationship between ADT and CVD, but we really need some prospectively designed studies that are looking at this not in a post hoc analysis, but are actually targeting to look at these cardiometabolic parameters. And I'm not going to rehash the data that Dr. Slovin has already shown us, but I do wanted to touch upon this study, which is a recent large observational Swedish trial of over 41,000 men with prostate cancer on ADT versus age-matched prostate cancer-free comparison group. And what they showed was a 21% increased CVD risk in men on GnRH antagonists compared with their control group. Now, in terms of timing, we've talked about timing for metabolic aberrations to occur, which doesn't seem to take very long for bad things to occur. And the theme is then repeated with cardiovascular disease, where we see that the CVD risk is highest in the first 6 months. And who is particularly high risk is, again, this is not going to be a surprise to most of us that take care of patients, is patients that have already had a cardiovascular event or two in the year prior to starting therapy. So this is going to be really your high risk patients, the older patients, the patients that already have cardiovascular disease or have poorly controlled or poorly managed cardiovascular and metabolic issues. So as Dr. Slovin had pointed out for us, that there was an advisory that was put out by American Heart Association in collaboration with specialty organizations in 2010. And this is what I show you here in this slide. In this panel, the bigger stake was held by urologists and oncologists. And I thought the document did a really good job of summarizing the literature, of highlighting the risk of androgen deprivation, and also highlighting the inconsistencies in the data that we've been talking through this podcast about. It also made some astute observations regarding health maintenance and primary and secondary prevention. However, it was a summary statement that was somewhat surprising to a lot of us that take care of patients, which was, let me actually read it from here. It says, despite the metabolic effects of ADT and the possible increased cardiovascular risk, it is the consensus of the writing group that there is no clear indications for patients for whom ADT is believed to be beneficial to be referred to internists, endocrinologists, cardiologists for evaluation before initiation of ADT. And I think in the current model of cancer care, it is wrong to assume that the oncologist is willing or able to act as an internist, cardiologist, and a subspecialist to take care of these very, very complex issues in patients. What do you think about that, Dr. Slovin? Is that?
I agree with you completely. We become chief cook and bottle washers, so it's really important that multidisciplinary care be ongoing.
Yeah, absolutely.